whenever I talk about sodium, you know, uh, I feel thrilled. Sodium is the boss, and it's very important in many like regulating many electrolytes. Anyways, remember that in newborn the amount of fluid is like might reach like 80%. And with time, the fluid is getting less. With the adult time, that the man would have 60% and the woman would have like 50% of their body weight is fluid. And the other thing is that seniors as well, that when we get older, the amount of fluid, which is usually in the muscles getting less. That's why the amount of fluid is getting less. And this is very important in understanding and managing hyponatremia. Impaired water excretion is the main reason for hyponatremia, i.e., the low sodium most of the time is not because that the body is depleted of sodium. No, the water is more compared to the sodium, and the main thing is the antidiuretic hormone is the reason. It means that it's not allowing the water to get out from the body, and this might be because of two things. Either there is SIDH, it means that the ADH is there inappropriately, despite the sodium is low, the osmolality is low, but the ADH is still working. That's why we call it inappropriate ADH secretion. Or no, the ADH, it might be there because there is good volume, but that volume is not effective. It means that the intravascular volume is high, but the heart is not pumping, the heart is failing, or the kidney is not seeing that fluid because it is directed, shunted to the suprachiasmatic area in liver cirrhosis. That's why the both of them, the heart failure, liver cirrhosis, could still cause sort of ADH secretion, or there is a true volume depletion. But the ADH to be secreted anyways, in response to low volume, it needs really low volume, like severe volume depletion. But ADH is secreted easily whenever there is an increase in osmolality, even in like level of 1 or 2%. The hormones that affect the sodium are many, and the main ones are the renin-angiotensin and the aldosterone, as you know, that reabsorb sodium mainly. And the other hormone is ADH we talk about, and the atrial natriuretic peptide that promotes sodium excretion in case of high blood pressure or stretching of the atria. As I said, the sodium is the boss, and the sodium is mainly reabsorbed in many places, in fact. But the fine tune, the very important cell is the principal cell in the collecting duct, and this is the ENaC channel where if there is extra work or what we call gain mutation in ENaC, this would cause more sodium to be reabsorbed. More sodium to be reabsorbed, it means this mineralocorticoid will be very active in getting sodium in, potassium out. So sodium in, volume retention, high blood pressure, potassium out, low potassium. This is the Liddle syndrome. Always remember the amount of sodium in different types of a fluid. Like half saline, half 77, which is half of the normal saline, which is 154. The lactate ringer has 130 millimole, and the 3% has 513 or 12. And of course, the 5 water has nothing. The pseudohyponatremia, it means that the serum osmolality is normal. And always keep this in your mind. Most of the time, we don't have the measured osmolality. What we have is the calculated one. So if you plot or you apply your numbers in that equation, it will give you low osmolality, which is wrong. Pseudo-hyponatremia, normal osmolality, and that should be the measured one, not the calculated one. What could cause pseudo-hyponatremia is hyperproteinemia, because the aqueous part of the plasma has been shifted because of the lipids or protein, and this would cause our labs mistakenly calculate the sodium wrongly, that it is low. And there are labs could do the right sodium level, but that need like sophisticated ones. When you have low sodium, that is below 135, the first thing, again, glucose. Is there hyperglycemia or no? If yes, then calculate the corrected sodium. So for every 100 milligram of glucose, above 100, you could add 1.6 to your serum sodium. And if that normalizes your sodium, it means this is just hyperglycemia-induced hyponatremia. Correct the glucose, the sodium would be fine. If there is no hyperglycemia, then could extracellulose be present in the serum? Is there possibility that this patient has, for example, intravenous mannitol, has surgery that prostate or uterine surgery were flooded with hypotonics that could cause this or not? If this is the answer, then you have to measure the serum osmolality. If it is not, there was nothing of those, then is there reason to suspect pseudo-hyponatremia, like serum lipemic, patient is jaundiced, and is there history of plasma cell dyscrasia? We're talking about multiple myeloma, for example, like paraproteinemia. So then you measure the serum osmolality. So let's just go back a bit. We're talking about a patient who's having received intravenous mannitol or IVIG, or has postoperative after prostate or uterine surgery. Then you measure the serum osmolality. If it is normal or high osmolality, this isoosmolar or hyperosmolar hyponatremia may be because of the absorption of the glycine or sorbitol. They are hypotonics that would cause hyponatremia. Patient with suspected pseudo-hyponatremia should have sodium measured be directly. This is what I was telling you, this specific special type of labs that could detect the pseudo-hyponatremia. Anyways, if there is no reason to suspect pseudo-hyponatremia and the osmolality was low, so this is the real hypotonic hyponatremia, then you could ask, what is the EGFR? If EGFR is low, this is renal failure, because the kidney is not able to get rid of excess water. That's why the sodium will drop. If there is no renal failure, any thiazide on board or not. If thiazide is there, stop thiazide, reevaluate hyponatremia. If it is resolving, this is the thiazide induced. If it is not, this patient edematous, to think of hypervolemic type of hyponatremia, heart failure, or cirrhosis as a reason. If no, then sign of hypovolemia, to think of, let's say, hypovolemic hyponatremia. And here where the physical exam is important. Always make sure that you evaluate your patient volume in a good way, in a good time. So then you measure urine sodium. If urine sodium is like 25 to 40, this is vague. Maybe this patient received fluid or he's in halfway. You could infuse isotonic saline over 1 hour, re-measure the urine sodium and see. If it gets changed to like below 25, your patient is hypovolemic and the loss of sodium is not in the kidney, is somewhere else, GI, for example. If your sodium is high, is above 40, then your patient is losing the sodium and the volume in the kidney. And the reason might be because of medications you're giving, or there is problem in cortisol, or let's say the mineralocorticoids, not the cortisol. Mainly, we're talking about aldosterone, in fact, and maybe there is deficient, or there is, for example, head injury causing cerebral salt wasting, or use of diuretics, or primary adrenal insufficiency. Yeah, so if there is no signs of hypovolemia, they measure urine sodium and urine osmolality. If urine osmolality, is it below 100 or not? Remember that if there is hyponatremia, what should the urine osmolality be? Let me just ask you, let me wake you up. Just answer in the chat or unmute yourself. If there is hyponatremia, what should the urine osmolality be? High or low? Let's say below 100 or above 100. See, yeah, it should be low. Excellent. It should be very low because it should be water. It should be, in fact, water. So if urine osmolality is below 100, if it is yes, then urine osmolality measured after therapy initiated or not. If it is yes, this is recovery from mild hypovolemia, for example. The patient was hypovolemic, sodium was low, you gave saline, for example, you restored the volume, some water is a bit, was higher than needed, or not the volume, I mean, higher than needed, and the water as well. So that's why the kidney is getting rid of some water. That's why the urine osmolality might be low. Otherwise, it was high. So if this is after therapy, it means that the patient is recovering from mild hypovolemia. If it was not after therapy, patient with rapid water consumption or not. If it is no, he's not drinking, then this might be like tea and toast, that there is no much water, but there is no much salt in this patient, in fact. If it is yes, this psychotic patient, like drinking lots. That's why the kidney is getting rid of the water, and it's not like it's not up to the level of the ingested water. If urine osmolality is not below 100, then we ask ourselves, what about urine sodium? It means that urine osmolality is above 100. Okay? Then what about urine sodium? Is it above 40? If it is no, then ensure sodium intake. Was it more than 150 over next 24 hours by infusing a liter of isotonic saline and remeasure the urine osmolality and sodium. So if urine sodium is below 40, and I mean after you infuse, and urine osmolality is below 100, then this is a hypovolemic. If urine sodium is above 40 and urine osmolality is above 100, then you evaluate for glucocorticoid deficiency and hypothyroidism. Then if AM cortisol and ACTH were done, if they were abnormal, so this is glucocorticoid deficiency. If it is not abnormal, then TSH is TSH very elevated or not? So if yes, severe hypothyroidism. If no, this is SIDH. The question is, do we need to do all of those things? Well, many times no. Like history is important, physical exam is important, and the case scenario is important. So major causes of hypotonic hyponatremia: primary polydipsia, psychosis, low dietary solute intake, as we said, like tea and toast. Many of them, they are depending on tea and toast. They are hypertensive. They are taking thiazide, and you can imagine it's just multifactorial because all of those. Disorder with impaired urine dilution, advanced renal impairment, of course, diuretics, and disorder with impaired urine dilution due to unsuppressed ADH secretion. And we mentioned a couple of those. It's IDH with many reasons, medications, the problem in the CNS and the lungs, malignancies, and then the throat depletion of hypovolemia as well, which, as we said, it will stimulate ADH. So I think the reset osmostat for chronic illness is important in elderly, and this is many times you could see them like chronic hyponatremia, asymptomatic. They come to the hospital with a level of 125 or so sodium. Maybe this is their usual or their new baseline. Don't jump and change much there if they don't need. Just skip this. Yeah. This is the most important thing. When you have a patient with hyponatremia, history is important. What is the intake? Is there gastroenteritis? What is the insensible loss? If the usual insensible loss is 600 to 900, this could be raised by 2.5 ml per kg per day because of 1 degree fever. So 38 temperature will increase the insensible loss. Then you should see your patient. Is he tachypneic or not? Is he having burns? And you need to know how to calculate the fluid deficit by the Parkman formula anyways. Is he on mechanical ventilation versus dry air? Mechanical ventilation does not cause water loss, but dry air would cause water loss. Then physical exam. Who is doing JVP assessment these days? I don't think people, they are up to it. They have in their hands, they're carrying the iPads, they're carrying the maybe laptops, and there is no time to do the JVP assessment. But believe me, it is essential in hyponatremia. And make sure that you're doing it. When we come to the volume assessment, if your patient looks like hypervolemic, this hypervolemia, it might be water more than sodium. That's why this would cause low sodium in the serum or hyponatremia. Then you check the urine sodium. Is it below 20? If it is below 20, you're seeing your patient is puffing, but you go and see urine sodium is below 20. This might indicate nephrotic syndrome, cirrhosis, cardiac failure. So kind of volemic or dilutional hyponatremia. But if urine sodium is high, it means that your patient is hypervolemic, but the urine sodium is high because the kidney is not doing the job. The kidney is failing. In a euvolemic patient, the sodium does not change much, the pool of the sodium, but the total body water is high. Urine sodium at this stage most of the time is high. This is what we see in its IDH. And before we say it's IDH, because it shares the same thing, which is high urine sodium and glucocorticoid deficiency, the hypoadrenalism or hypothyroidism should be ruled out. And in hypovolemic patient, the sodium is more lost compared even to the water. That's why urine sodium most of the time is below 20 in extrarenal losses, but in renal losses, you will see it more than 20 anyways. How do we treat? It depends on the duration, severity, and symptoms. Acute versus hyperacute hyponatremia. So within 24 hours is acute, and just in a few hours is hyperacute. Hyperacute could happen in marathon runners if they overdrink water, because marathon runners, they're losing water. They're liable for hypernatremia. If they overdrink water, this might cause significant low sodium, like hyperacute. Psychotic patients and ecstasy. Chronic hyponatremia, always remember this picture. It's like a turtle carrying like a missile or rocket. The thing is, the chronic hyponatremia most of the time asymptomatic, but the treatment might cause, catastrophes. Of course, more than 48 hours of the duration is unknown. It is chronic hyponatremia, and the severity mild, like 130 to 135, and severe is usually 120 or less. Symptoms, it depends not just on the level of the sodium, it depends on the age of the patient. So you have two brains there. You could see there is no space here, but there is space here. That's why this person is more liable to get, symptoms of hyponatremia compared to this. This is young, but this is old. So hyperacute again is more chance to develop symptoms, especially if he is young, compared to chronic and old. Mild to moderate symptoms, they are non-specific. I just focus on nausea and vomiting. Nausea and vomiting, I would say they cause hyponatremia by releasing ADH more than they are symptoms of hyponatremia. Severe symptoms, of course, we're talking about like neurological symptoms, osmotic demyelination, sodium raised by more than 10 to 12 within 24 hours, or more than 18 within 48 hours. Few cases have been reported after slower correction by even 9 millimole in 24 hours. So who are at high risk for osmotic demyelination? Severe hyponatremia, like below 105, hypokalemia, alcoholism, malnutrition, and those who have liver disease. Low risk, hyperacute, because hyperacute, in fact, if you just severe them immediately, that would not change anything because adaptation has not happened in the brain. So hyperacute, low risk for osmotic demyelination, and marathon runners, ecstasy, because they cause hyperacute many times. It is irreversible. That's why you should be careful, and the changes could delay. The manifestation might not, be clear until like most a week. It is irreversible. Whenever you have rapid correction, relowering would decrease the chance of osmotic demyelination. Relowering, I mean, relower the sodium. If you have sodium which is significantly increased, you relower it. Euvolemic patient, you restrict the fluid. The problem, how much you restrict, it's not just a liter. A patient who's 100 kg is not like 40 kg anyways, and you give salt. Hypervolemic, you give diuretics. Hypovolemic, you replace sodium, and you give desmopressin. Avoid rapid correction, 6 to 8 millimole per day in chronic hyponatremia, and please monitor urine output. When to give emergency therapy? Hyperacute. In hyperacute, even if there is no symptoms, because, for example, those who are psychotics, when they drink water and they drink quickly, you measure the sodium, you see it, let's say 125. Still, there is water inside their tummy. After like 30 minutes or an hour, you would see it like below 110. That's why you should be very careful. Hyperacute, even if there is no symptoms, because delayed absorption of used water, herniation may occur. I just skip desalination by now. Acute, and even in mild symptoms, they have mild symptoms. Young, don't wait. Severe symptomatic, of course, versus young asymptomatic with like significant low sodium, especially if there is intracranial pathology. Symptomatic patient who have acute post-operative hyponatremia, hyponatremia associated with intracranial pathology. Always remember, raising serum sodium by 5 millimole is efficient to prevent brain herniation. The IDH amount of fluid restriction should be proportionate to the body weight. which is body fluid, of course. And the criteria, urine osmolality is more than 100, and I think the rest you can just review them. I'll just skip this slide, it's complicated. Always put a goal for therapy for a patient who is having hyponatremia. What is your target? Of course, the first thing is avoid rapid correction. Ideally, the serum and urine lysis should be done every 6 hours. If we give therapy, I would just repeat in the first hour or two, and then we decide upon the subsequent lab. How do we treat severe chronic hyponatremia with mild or moderate symptoms? You could give a slow intravenous infusion of hypertonic saline at 15 to 30 ml per hour in combination with desmopressin. The amount of desmopressin, the dose, is 2 to 4 mic IV or subcutaneously every 8 hours for 24 to 48 hours. Do I do this? I don't give like for 24 hours. I just specify over how long I want to increase the sodium, and I give boluses, in fact, like 150. I calculate how much I want, and I just give them over like 20 minutes, and then redose based on the level of sodium. Maybe one day we'll talk about some practices. Acute asymptomatic hyponatremia, an intravenous bolus of hypertonic saline. This is acute. You can give a bolus. Even a chronic you can give if you're afraid of neurological symptoms. 50 ml, let's say over 10 minutes, then 2 to 3 additional boluses. You can give even 100 over 10 minutes. That's not a big deal. In patients with moderate symptoms, an initial 50 ml bolus of hypertonic saline may be justified prior to beginning the slow infusion. Oh, you have a practice here. I thought there wouldn't be. 60-year-old gentleman presented with decreased level of consciousness. Sodium is 115. Weight is 70 kg. So the first thing is this chronic versus acute. And then we have to ask ourselves how much we should increase this patient. She's having symptoms, right? She's having decreased level of consciousness. Then we should ask ourselves how much we should increase the sodium. We want to make it 120. And this 120, within 4 to 6 hours, still it is safe to increase it by 5 points over 4 to 6 hours. In fact, that would risk the brain. That would prevent any brain edema from happening. That's why it would save this patient. So how could we increase? You see, we need to increase from 115 to 120, which is 5 millimole per liter. And this patient is 70 kg times 60% of his body weight, that is 42 liters. Means I have to multiply 5 per 42, because 5 millimole per liter multiply by the total liters he's having, which is 42. So the total sodium I need is 220. If I want to give 3% saline, I know that in 1 liter 3% saline, there is 512 sodium. But I don't want 512. I want only 210. Then I will do the double cross, and this would give me an X of 410 ml. Amount of 3% I need to give to raise the sodium from 115 to 120 in this patient. What if I want to give a 0.9? It would be the same thing. The only thing that this would be 154, and then you do the double cross, you will get, 1,363. No one will give this patient in like 4 or 5-6 hours, 1,363. And the thing is, might not work anyways. That's why 3% is indicated here. Who will not be good candidate for desmopressin? Not everyone you go and give desmopressin or ADH, analog. Avoid desmopressin in patients who are at high risk for self-induced water intoxication. Imagine that your patient is psychotic and he's drinking water. You're giving him desmopressin, preventing water from being excreted by the kidney. Oops, you will see the sodium below 100. So you should be very careful. Psychotic patient, edematous patient, heart failure, because still you need those to, excrete the fluid. Chronic SIDH who have recurrent hyponatremia. That's why the edematous patient, you might give furosemide with hypertonic, but this should be under certain conditions, because Lasix might get more water compared to sodium, and that might cause rapid correction. What about hypernatremia? Whenever we have hypernatremia, we think that this is because of water loss. It's not just water loss. It might be sodium gain. That's why the setting is like this. Patient in ICU, you were called and you went to see, they are hypernatremic. ICU, they are not giving much water to their patients. This is very well-known fact. But it's not just water loss. Maybe they are giving 3%, let's say. They are giving sodium bicarbonate. They are giving medications, all diluted in sodium-containing fluid. That's why you should assess that. Diarrhea usually is mainly they're losing fluid, which is water. That's why it's a reason for hypernatremia most of the time, except few cases, like patient with cholera, for example, they have secretory diarrhea, or VI coma, they could have secretory diarrhea as well. Vomiting, the gastric fluid is mainly water. It's not sodium. It's just mainly water. The thing is, they don't develop hypernatremia because, they could replace, and that's why it's, if it would cause hypernatremia. I'll skip mannitol. I just added this for an extra, gifts, but there is something called transient hypernatremia that could happen with exercise. In fact, major causes of hypernatremia. Whenever you have a hypernatremic patient, in fact, take it seriously. This patient is seriously ill because either the first is not working, or the first is working, but he is not able to, seek water, or he is neglected. So, and replace water loss, insensible. Water loss is high. Gastrointestinal losses, osmotic diuresis is there. Glucose, for example, mannitol use, or there is hypothalamic lesion affecting the thirst. Water loss into cells, we say that this is transient in exercise, for example, that it could happen. How would we diagnose? Do we need that much to diagnose, reason for hypernatremia? It's either water loss or it's just, sodium gain. Well, if it is not clear, then you need to go through algorithm. What about the urine osmolality? If urine osmolality is below 600, you give ADH and observe the change of the urine osmolality. Plasma osmolality above 295 milliosmol per kg will tell you that the serum sodium concentration most of the time is at this range, which is 145, 147, and generally this would lead to sufficient ADH secretion. You remember that I said 1% change in osmolality would, stimulate ADH secretion. if hypothalamic and renal function are fine, the urine osmolality in presence of hypernatremia should be above 600. Hypernatremic patient, they have hyperosmolality. So they need water. So that's why the urine should be very concentrated. You see it like 600 millimole or more. If you give ADH for this patient, if the kidney is intact and responding to ADH, that would not change the osmolality. So urine osmolality in hypernatremia should be maximum, more than 600, and urine osmolality below plasma osmolality, that is 300. Then either there is central or nephrogenic DI. There is loss of water despite of hyperosmolality, means there is problem in the ADH, either central or nephrogenic. Intermediate osmolality between 300 and 600, it might be osmotic diuresis or diabetes insipidus. You measure the total solute excretion. People, they eat around 600 to 900 milliosmol, that from sodium, potassium, whatever, protein. And if you measure and see the urine solute more than 1,000, this will cause, like what glucose is doing as well, which is osmotic diuresis, will not respond to exogenous ADH. It's not the problem of ADH, it's the problem of solutes, in fact. 600 milliosmol per kg in dehydrated patient, extrarenal water loss, that the patient is dehydrated, but the kidney is doing the job by concentrating the urine. So there is extra renal water loss, and partial DI is still possible. Repeat urine and plasma osmolality after hypotonic fluids. I think till here is fine. The treatment, in general, a net positive balance of 3 ml of electrolytes free water per kilogram of lean body weight will lower the serum sodium by approximately 1 millimole per liter. What does this mean? In general, if you give 500 D5 water to a patient, but average body weight, this will drop the sodium by 1 to 2. Not much. Always remember this. Let's just go to this practice. 70-year-old lady presented with decreased oral intake. She had uncontrolled DM. Sodium was 166. Glucose is 400. Weight is 60 kg. You correct the sodium. The corrected sodium would be 170, in fact. It's not just 160. So this patient is really hypernatremic. So how do we calculate the water deficit? 170 sodium is dissolved in 30 liter fluid, like 50% of our body weight, right? I want to drop it by 8. I want to make it 162. So how do I do that? I do the double cross. 162 times 30 divided by 170, it gives me 28.5. Was 30 liter, and right now is 28.5. What does this mean? It means the difference is 1.5 liter. 1.5 liter, I added the insensible loss, which is 500. It means that I need to give this patient 2 liters over 24 hours. You can divide it into IV versus oral, that's fine. If you use the water deficit formula, you should use it not over, 24 hours, either 48 hours. If you set the sodium in water deficit formula into like 162, it will give you almost the same.